All right, let's talk about insulin therapy. It's an absolute cornerstone of diabetes management, right? But it's not without its challenges. The side effects can be tricky. So in this explainer, we're going to dive deep into the essential clinical strategies you need to know to manage them effectively.
Educational content by Dr. Mohammed El-Nagi Mohammed.
So here's what we've got on the agenda today. We're going to break down the key side effects of insulin. First up, we'll tackle managing hypoglycemia. Then we'll get into the tricky issue of hypoglycemic awareness, or the lack thereof. After that, the emergency glucagon protocol, which is crucial. We'll also look at lipodystrophy, and finally, we'll wrap it all up with some really high-yield takeaways, perfect for your daily practice and especially for those of you prepping for exams. Ready? Let's get started. Okay, let's dive right into the big one. We're starting with the most common and, frankly, the most acutely important side effect you'll encounter: hypoglycemia. Getting a solid grip on how to recognize and manage this is absolutely fundamental for anyone who prescribes insulin. It's non-negotiable. So where do we start with management? Well, it all begins with patient education. It is so important that our patients know how to spot the early warning signs of a hypo. We're talking about those classic symptoms, right? The sweating, the anxiety, maybe some blurred vision. And you also get those changes in mental state, things like confusion or even aggression. They need to know what to look for. Okay, so let's say you have a conscious patient who's having a hypo. The protocol here is actually pretty straightforward. Step 1, and this is critical, make sure they're alert and can swallow safely. No good giving them something if they can't. Then you're going to want to give them 10 to 20 grams of a fast-acting carb. Think a glass of a non-diet drink, some glucose tablets, or that glucose gel. The whole point here is rapid absorption, right? We need to get that blood sugar up and fast. All right, that's the straightforward case. But this leads us into something a bit more challenging, a really tricky clinical scenario: hypoglycemic unawareness. This is where patients actually lose the ability to sense that a hypo is even coming on. And that's a big problem. And you can see why this is such a huge risk factor for severe events. What's happening here is that after someone has repeated hypos, their body's autonomic response just gets blunted. There's a term for it: hypoglycemia-associated autonomic failure. Basically, the body just stops sending out those classic adrenergic warning signs. And because of that, patients can just plummet into sudden, severe neuroglycopenia without any warning. Now, how do you manage this? This is where it gets a little counterintuitive, so stick with me. To actually restore that awareness, we might need to relax their glycemic targets for a bit. Yeah, I know, it sounds weird, but by letting their blood sugar run just a little bit higher for a while, we can help reset the autonomic nervous system. It's like rebooting the system so that those crucial early warning signs can start to come back online. Okay, here's a really key point, and if you're studying for the MRCGP AKT exam, you'll want to highlight this one. We've got to talk about the interaction with beta blockers. Think about it. Beta blockers, well, they block the adrenergic response, so they're going to mask the most common warning signs of a hypo, especially things like a racing heart or tremors. Now, what's interesting is that sweating might still be there because that's cholinergically mediated. This interaction is an absolute classic exam topic and just a vital pearl to have in your clinical toolkit. So what happens when things go really wrong? What if the patient can't self-treat? This brings us to the emergency protocol for severe hypoglycemia. And this is something that every single patient on insulin and their family needs to be prepared for. So this poses a really critical question, not just for us as clinicians, but for our patients too. When exactly is a glucagon kit absolutely essential? And the answer, the indication, is crystal clear. A glucagon kit is for those emergency situations where the patient simply cannot safely take carbs by mouth. Maybe their consciousness is impaired, or they just can't swallow. You give that intramuscular injection of glucagon, it stimulates the liver to break down glycogen, and boom, you get a rapid increase in blood glucose. It's a lifesaver. Okay, so we've covered the acute metabolic stuff. Now let's shift gears and look at a really common long-term physical complication, one that happens right at the injection site. We're talking about lipodystrophy. Clinically, you'll see lipodystrophy in one of two ways. There's lipohypertrophy. These are those firm, kind of rubbery lumps that form because of insulin's fat-building effect. And then there's the less common one, lipoatrophy, which looks like pitted areas where fat has been lost. Now, this isn't just a cosmetic issue. The real clinical problem here is that injecting insulin into these spots leads to totally erratic and unpredictable absorption. And that, of course, can completely destabilize someone's glucose control. So given how much this can mess with glucose control, prevention is everything. So what's the single most effective piece of advice we can give our patients to stop this from happening?
It's actually incredibly simple. Rotate the injection site consistently. That's it. This one piece of patient education is just so vital. By rotating the sites, you prevent that repeated local trauma and the high insulin concentration that causes these changes in the fat tissue underneath the skin. Simple, but so effective.
All right, let's bring all of this together. We're going to wrap up by consolidating the most important bits into some key takeaways that you can use in your day-to-day practice and, of course, for any exam revision you're doing.
This summary here is super high yield, perfect for a quick review. So for hypoglycemia, remember the rule of 15, starting with 15 grams of fast-acting carbs. And don't forget that AKT pearl about beta blockers masking the symptoms. For lipodystrophy, the magic word is rotation, rotation, rotation. That's your key preventative strategy to fix that erratic absorption problem. Pulling all this together is really what's going to make the difference, both in the clinic and on exam.
And that brings us to our final thought for today. Look, we've gone through all the clinical protocols, but we all know that truly effective diabetes care is about more than just treating side effects. The real question, the fundamental one, is this: how do we take all this knowledge and use it to truly empower our patients? How do we help transform them into confident, active partners in their own insulin therapy? That's what it's all about.